Good afternoon, everyone, and welcome to the Safer Air Project's first live webinar session. I am Plum, CEO and founder of the Safer Air Project, and I'm delighted to welcome you all today to talk about why safer shared air in healthcare should be seen as an urgent priority for patients, carers, and staff. Before we begin, I'd like to start by acknowledging the traditional owners of the land on which we gather today. I am joining this webinar from the land of the Darramaragal people, and I pay my respects to elders past, present, and emerging. If you would like to do so, please feel free to say hello in the chat and acknowledge the lands from which you are joining us today also. Before we begin, a few housekeeping items. If you would like to add closed captions, you can do so by going to just to the right of the screen under More and going to Language and Speech, and that will give you the options for turning on live captions. The meeting is being recorded and transcribed and will be available on our website after the meeting. So don't worry if you miss anything, you'll be able to watch it again. Okay, so following a brief introduction on today's topic, I will introduce each of our special guests and invite them to say a few words about themselves and their interest in today's discussion. When we have heard from all our guests, we will then have a panel discussion, exploring some of our own questions before opening the discussion up to the audience. We encourage you to add your questions to the Q&A box as they come to mind. This is being moderated, and we will try and get to all your questions. If we don't get to your questions, we will do our best to forward them to the panelists after the session is completed. So please make sure you say who you are addressing the questions to, or send the question to a specific panel member by emailing info@saferairproject.com. At the end, we will bring you up to speed with the Safer Air Project and our latest work and how you can get involved. Finally, a word of thanks to our major sponsor, Camphil, and our supporting sponsors, Erlab USA and Sealy International. We sincerely thank you all for your support. So without further ado, let's get started. Today is the first of our Safer Shared Air webinar series, focusing on the role of shared air in healthcare. Since the start of the pandemic, we have seen a significant rise in the transmission of airborne viruses. When a virus is airborne, it hangs in the air like smoke, spreading through both long-range transmission, where infectious particles linger and travel across a room, and short-range transmission, occurring when people breathe out concentrated viral particles next to another person. Imagine you're in a room with someone who is smoking. When you're close to that person, the plume of smoke may be hard to avoid, but even across the room, you're going to be smelling and breathing in that smoke. So in the same way that smoke will accumulate in a poorly ventilated room, viruses do as well. So without safe indoor air quality standards, viruses accumulate and increase the risk of exposure for everyone in a shared space. Unfortunately, the increased risk of airborne pathogen transmission is an ongoing problem that disproportionately affects people living with chronic health conditions and other risk factors, as they face significantly higher risks of poor health outcomes from infection. For a long time, we have known that people living with chronic health conditions are more vulnerable to severe illness from many viral infections. People with cardiovascular disease, diabetes, transplants, cystic fibrosis, cancer, autoimmune diseases, and many more, including the very young and the elderly, have routinely been advised by their clinicians to avoid infections to protect their health. This advice has shaped many aspects of their lives, affecting travel, work, healthcare, childcare choices, and even decisions about whether or not to have children. Despite the ongoing pandemic, there remains a widespread lack of recognition that poor indoor air quality increases the risk of airborne pathogen transmission and reduces accessibility to indoor spaces for people who are at higher risk of poor health outcomes from infection due to exposure to airborne pollutants. Nowhere is this more critical than in healthcare settings. As we discussed in our November 2024 report, Safer Shared Air, a critical accessibility and inclusion issue, Every person has the right to safe healthcare, as outlined in the Australian Charter of Healthcare Rights. This means that access to care that meets their needs, to care that is safe, and to care that respects their dignity. However, without safe indoor air quality standards and effective airborne infection prevention policies, these rights are often not upheld, especially for people with chronic health conditions, disabilities, or other vulnerabilities, such as their current acute need to access healthcare. Data from hospitals in Victoria and New South Wales reveal alarmingly high mortality rates for healthcare-acquired infections, forcing many at-risk people to avoid seeking necessary medical care. Our greater understanding since the start of the pandemic of the airborne nature of many viruses requires us to deliver a paradigm shift in how we assess and manage risk in healthcare settings that we will explore today. Our vision at the Safer Air Project is to create a world where everyone can breathe safely indoors. We're committed to promoting equitable access to clean and healthy indoor environments by empowering communities, especially people with lived experience, to share their stories, advocating for inclusive policies, and collaborating with stakeholders to implement solutions that ensure every person, regardless of health status, can safely access the spaces they need. Through our discussions today, we hope to shed light on the challenges faced by people living with chronic health conditions when accessing healthcare. We will also explore the roles of clinicians, infection prevention experts, building operators, and policymakers in ensuring equitable access to safe healthcare. With insights from our panel members, we will hear important perspectives on the risks faced by people working in and attending healthcare facilities. We'll also explore how technology and policy can work together to improve indoor air quality and raise awareness of buildings that provide safer shared air for everyone. By listening to the lived experience of patients, we can better understand the challenges they face and refine the solutions that we put in place. We hope this session helps drive progress in addressing the impacts of poor indoor air quality on patients and healthcare workers. And we thank you all for being here today and look forward to an insightful and impactful discussion. So it's time to bring on our first speaker. Our first guest is Donna Ciccia. Donna is a leading advocate for women's health, renowned for her co-founding of Endometriosis Australia. With over 2 decades dedicated to improving women's health, Donna has tirelessly worked to increase awareness, provide support, and drive research for endometriosis, a condition affecting millions. Her advocacy extends to broader health issues, collaborating with health organisations and government bodies to secure better healthcare policies. Donna is a devoted wife and mother, and her efforts have garnered numerous awards, solidifying her legacy as a changemaker and champion for women's health and well-being in Australia. We're really delighted to welcome you today, Donna. Thank you very much for joining us. And if you'd like to give an introduction, we'd love to hear from you.
Thank you, Plum. It's a delight to be here today. I think clean air and the importance of it really has been solidified over the last 5 years. And knowing that women and women with endometriosis or people with endometriosis are disproportionately impacted by COVID, that was another, I think, another impetus for me to be involved in this space. I also have a son living with or existing with long COVID, and I have decided to champion him and help him find a way through this period in his life and hopefully help find a cure for long COVID. Helping a group of people start up Long COVID Australia, so hopefully that will be on the horizon in the coming months. I don't understand why patients aren't at the centre of clinicians in their GP practices, in their specialist practices, There isn't clean air. It's not even an afterthought. It would be brilliant to not be asked to take off my mask, or my son to do that every time we go to medical appointments. It would be, I think of utopia, and I know that I've lived with a chronic illness all my life. The last thing I wanted was for my child to be living with a chronic illness. So anything I can do to help raise awareness and help create change for the next generation, that would be an absolute dream. And I don't have a huge amount of things to say, but I just am very passionate about the patient's voice front and centre, and patients being heard and being part of the co-design process in whatever research that may need to come along, in whether it's in shared clean air, or whether it's in COVID, or whether it's in women's health and endometriosis. So thank you, Plum, for having me here today.
Thanks, Donna, and thanks for the introduction and for sharing your story and the challenges that your son has been facing. As someone who's also living with long COVID, it is really tough. It's really tough accessing healthcare as well, and having to advocate like that. That's obviously why we're here today. So thanks very much, and thanks also for stepping up and getting long COVID Australia moving. It's really needed.
Yes, thank you.
Okay, so thank you, Donna. That was fantastic. We're now going to hear from Glen. So Glen Ramos has over 30 years experience in healthcare policy and advocacy as a senior executive and director. This includes initiating, influencing, and instituting public inquiries, judicial inquiries, and legislative changes at state and Commonwealth levels, resulting in policy change, improvements to injury and communicable disease prevention, access to mental health services, and access to specialist medical services. He is a director of the Australian Health Promotion Association and National Councillor of the Australasian Epidemiological Association. Thank you for joining us, Glen. I'm going to just remind you to unmute and turn your camera on if possible. There you go. Wonderful. Good to see you.
Thank you, Plum. It's a pleasure to be here. I'm excited to be here, actually, share my story. And I'm also a little bit disappointed too, primarily because we need to have these types of events, that we actually need to push and request and lobby and advocate for what should be a very fundamental healthcare issue that affects people like me. In your intro, you mentioned my healthcare policy experience. I'm here today essentially as a person who has a healthcare condition. I've lived with cancer for 20 years, nearly as long as I've been in the healthcare space of 30. So I've been able to see along that time, not only just as a policy person, but as a person who actually lives with a serious healthcare condition, both sides of what happens in this space. Indoor air quality is absolutely critical for people, not just with chronic conditions. It's obviously a given, but it's fundamental for all of us in many ways. So I think it's an important process for us to go through these types of events, to keep advocating, to try and get some indoor air quality standards, and hopefully as being part of this process, we can work towards that. So I appreciate the invite and participation. Thank you, Plum.
Thanks, Glen, and thanks for sharing your experience. I think I've always thought with you and I, our worlds first collided, through rare cancers, where I was, the head of policy and public affairs. So our policy background and our journey to this has been similar. And I'm, it's just really great to hear from your patient perspective, the importance of acting on this. So thank you very much for sharing that. Okay, So moving on, we are now going to bring on Dr. Bronwyn King. Hello, Bronwyn. Dr. Bronwyn King is pleased to be working with the Burnet Institute and University of Melbourne to help advance Australia's progress on indoor air quality, building on lessons from Australia's world-leading approach to tobacco control. Dr. King has convened a series of indoor air quality parliamentary roundtables for Australian politicians and led the development of new collaborations and partnerships amongst a broad range of stakeholders, from academia, advocacy, industry, business, and government. In August 2024, Dr. King was pleased to brief the Australian Prime Minister on the issue of indoor air quality. Dr. King is a radiation oncologist by background and founder and CEO of Tobacco-Free Portfolios, an NGO with a global footprint. In 2019, Dr. King was named Melburnian of the Year, and we're delighted you're able to join us today to share your experience.
Thank you so much, Plum, and a warm welcome to everybody. I can see online there's even people from the US who've stayed up late to join us, so a special warm welcome to anybody who's joining us very late or very early in the morning. I think just to sort of extend from that very kind introduction, I'd like to say that even though my background has been in other areas of health, in about the past sort of 3 years, I've been really focused on the issue of air quality and very keen to see further progress with regards to indoor air quality standards, not just in Australia, but hopefully throughout the world. When the pandemic hit, this was really a defining moment in my area of interest, because it became apparent very early on that COVID was an airborne disease, even though there was that terrible mistake and we were all told to wash our hands and wipe down our grocery products. In fact, it was an airborne disease. Very early on, we found out that there were long-term consequences associated with getting COVID. We knew that immunity was short-lived and incomplete from vaccines or getting the disease itself. So repeated infections were going to be expected. And we were also told very, right at the start, that it was completely out of control and COVID was always going to be around. And when I put all of that together, I kept thinking, well, we're going to have to clean the air. I mean, isn't that the long-term systemic solution? And with that, that's really been sort of the driving force behind all of my work in this area. And it's been such a pleasure over the past couple of years getting to know so many experts in such a range of disciplines who are all working towards this same goal. A few key points just to make in these introductory remarks is that by background, I am a radiation oncologist. I'm actually retired now. I've been retired for just over a year, but I had a 20-something year career in radiation oncology, looking after some of the world's sickest patients at the most vulnerable point in their lives. And so that really frames a lot of my thinking here. The first point I'd like to make is that healthcare should be safe, and it should not be controversial to want that or expect that. And in fact, in Australia, we explicitly have, as Plum mentioned, the Australian Charter for Healthcare Rights. And that states that we all, as patients in Australia, have a right to safety. And that, I just want to read what that means. That states that patients have a right to be cared for in an environment that is safe and that makes you feel safe. And unfortunately, I would argue that at the moment in Australia, we are not being true to that charter. And we really need to acknowledge that and do what we can to make that right. As a doctor, there's always the principle of the Hippocratic Oath as well. And I think as all healthcare professionals, we should remember that, first do no harm. And we should really sit with that and think, are we doing no harm in 2025? And I think it's hard to argue that we aren't. And again, that's very unsettling, and I think we can do better. The second point is that healthcare is not safe now. The data shows us that. And many people would be aware that in Australia, there was data released covering Victoria, New South Wales, Queensland and South Australia, showing that in 2022, 23 and 24, there have been many outbreaks of, if we just take COVID as one airborne disease, but there have been many outbreaks of COVID. They have impacted thousands of patients in public hospitals in those states. And those infections that people acquired while coming to hospital for something completely unrelated have resulted in a 5 to 10% death rate. And I think it is extraordinary that we are not acting on that with a bit more speed and attention, because that really is out of keeping with our current approach and our historical approach, working in the health sector for such a long time. Our historical approach to hospital-acquired infections is normally exemplary. If there is an infection or a hospital incident of any other kind, the hospital has a policy. It needs to be reported. There's an investigation. New policies and procedures are implemented all across the hospital. There's a new education program. It's implemented into accreditation processes, and everything is done to make sure that that particular hospital-acquired infection or incident never occurs again. And yet this is not happening with airborne diseases. And we really need to acknowledge that we are in a different environment now. COVID is all around now. It's not seasonal. It's not only winter. It's happening in regular waves. And even at the lowest points, there is still a considerable, substantial burden on our healthcare workers in hospitals. So it's never going away, and we need a better solution. And finally, before I pass on to our next speaker, I really want to mention what it has been like as an oncologist, because yes, I'm retired, but I spent 20 years in oncology caring for patients who really, really need good quality care. And I know firsthand how important it is to keep our patients as well as possible during that terrible time when they're being diagnosed and having their disease evaluated and then undergoing their treatment. They are extremely prone to all sorts of infections during that time. And every single one of my patients, I recommended to them, strongly recommended, that they do everything they can to protect themselves from getting any disease, but of course, airborne diseases, including COVID. I think it was very tough for me to do that, knowing that the patient had to take on so much of that obligation themselves in a way that we didn't ask them to do that for any other diseases. But in fact, it really fell down to the patient's responsibility to protect themselves from airborne diseases, in particular from COVID. And again, that's out of keeping with how we would act in any other way. If my patients got COVID, the impact of that was very significant. The impact of the disease itself, so they were much more likely to get a severe COVID infection. That would have a severe impact on them. But also there was a significant treatment impact. So their treatment would have to be delayed. It would have to be watered down, changed, or completely abandoned because they weren't in good enough shape to have that treatment. So, I mean, that's just cancer treatment. But of course, it follows that really anything that you're going to hospital for treatment for will be deployed better and will have a better impact of success if the patient is in as good a shape as possible at the start and during their treatment. So we absolutely want to make sure that our patients are protected from airborne diseases. And finally, just to mention, the really good news is that we actually know how to fix this problem. I've had the great pleasure of connecting with aerosol scientists, academics, engineers, building designers, hospital designers, architects, and facility managers, all of these incredible people, plus industry who make all of those clever products like ventilation and air purification systems. The technology's there, the science there is there. We know it works. We just need to take those next steps and make sure that our healthcare leaders see the incredible opportunity we have to do better in this space. Thank you very much.
Thank you, Bronwyn. That was an excellent introduction, and I've written a ton of notes that I want to come back to in our panel discussion, talking about healthcare workers, patient responsibilities. So tons to go on in our discussion. So thank you very much. But I also feel like your intro was a perfect segue to our next guest, who is Dr. Stéphane Bouchoucha, who is an associate professor in nursing and associate head of school international in the School of Nursing and Midwifery at Deakin University. Stéphane joined the School of Nursing and Midwifery in April 2015, and prior to this had over 20 years experience in the clinical setting and facilitating the learning of both undergraduate and postgraduate nursing and midwifery students in Australia, Hong Kong, the UK, and Singapore. Stéphane's research program has a focus on infection prevention and control. Well, you're here today. It's very exciting. Stéphane is the president of the Australasian College for Infection Prevention and Control, the ACIPC, which is the peak body for infection prevention and control professionals in the Australasian region. And we really are delighted to have you here today, Stéphane. Thank you so much for joining us, and looking forward to addressing some of the issues that Bronwyn raised.
Thanks, Plum, and thank you so much for inviting me and for the Safer Air project, really for raising awareness on this essential issue in healthcare. A lot of things have been said already, but I just want to take us back to the miasma theory, where which is really an outdated medical belief, where we suggested that disease like cholera, Black Death, were caused by bad air or miasma, a noxious vapor that was coming from rotting organic matter. So we have obviously moved on for that, and but I just want to argue that did we move a little bit too far away, and have lacked considering the role of indoor air quality enough in the management of our common respiratory infection? So we've got evidence now that miasma it's not a thing, but did we move too far? And I think the latest pandemic, the COVID-19 pandemic, is really a lesson in infection prevention and control, that we cannot focus on just one thing. And did we move the needle, the dial, a bit too much on hand hygiene at the detriment of respiratory protection? The beginning, as Bronwyn pointed out, the beginning of the COVID-19 pandemic highlighted some severe shortfalls and disagreements in the IPs, in the infection prevention and control community, and we need to move on from that and consider the evidence. Transmission of respiratory pathogen doesn't follow a one-size-fits-all with two modes of transmission, droplets and airborne, and we really know that we have a continuum now, and we should really change the terminology we're using. And as ACIPC, we're recommending changing that terminology to look at infectious respiratory particle to describe really the particle that contain pathogen that travels through the air, and recognizing that it is a spectrum, and we don't have this dichotomy with some pathogen falling on surfaces and some pathogen going in through airborne inhalation route. Obviously, Plum, you have mentioned Donna, Bronwyn, and you have mentioned the core business of infection prevention control teams is the control of healthcare-associated infection. So the fact that we don't have the same level of attention to healthcare-associated respiratory infection that we have to MRSA, for example, methyl-resistant Staphylococcus aureus, is quite distressing. As we know, healthcare-associated infection are extremely costly, and I'm not talking about money. I'm talking in terms of, loss of life, in terms of loss of person in your community. So we really need to also focus on respiratory infection. And I think the pandemic has brought that to more attention now. It's probably something that has been going on for a long time, but we are taking more attention to it now. And I really think we need to also consider that as community safety. So not just healthcare, acute healthcare settings. Donna was talking about GP practices. So, really having that as a whole and fully integrated infection prevention control as a whole of community approach to preventing communicable diseases. I've recently, a couple of days ago, come back from the Philippines, and there are air purifiers in a lot of places, much more than we're seeing in Australia. And we know that air purifiers, they're a great example of thing that the science indicate that they may make a difference, but how we use them and how we use them in healthcare settings, we need some research to support the use, making sure they turned on the filters and all that we no doubt will discuss. So I think with these are some of my thoughts as introduction, and I'm looking forward to the discussion.
Sorry, I was having some trouble unmuting. Thank you very much, Stéphane. It's great to hear sort of some of the thoughts around ACIPC and the spectrum, the change from, you know, droplet theory to, you know, infectious respiratory particles, which is the new language obviously out from the WHO. But also just I love the comparison to MRSA. You know, and perhaps we can get into it in the panel discussions. You know, what are the things that happen to prevent you know, if an MRSA infection occurs in healthcare, what are the things that happen, and why are we not doing the same when an airborne infection, you know, which is preventable, happens? So thank you very much, and I love that you also brought up about air purifiers and things that we can do from a building perspective, and that's what our next guest is going to talk about. So thank you very much, and we look forward to speaking in the panel discussion. Okay, so our final guest before we get to the panel discussion is Derek Shearer. Derek first entered the building services industry as an electrical apprentice in the UK in the early 1990s. Over the decades, he has become a seasoned professional with experience across multiple trades disciplines in the UK, Europe, Australia, and New Zealand. Prior to joining AG Coombs in 2023, Derek spent over 10 years at Johnson Controls, where he most recently served as their service sales leader and the healthy buildings leader in the Pacific region. He currently chairs the AIRAH Indoor Air Quality Special Technical Group, and if you like acronyms, it's the IAQ STG, and he is a well-accredited professional, which is a well AP. So thank you very much for joining us, Derek. Look forward to hearing your thoughts on how we can make the buildings safer.
Yeah, thanks, Plum. Really appreciate the invite to be with you all today. It's been amazing so far to hear the perspectives from I guess from a patient advocacy and medical professional point of view. But I come at this topic from more of an indoor air quality and safer shared air perspective. From
Hold on, Derek. Sorry to jump in. I think you've muted yourself.
Okay, I'm back.
You're back. You're back.
I'm back. I've spent over 20 years helping building managers and facilities teams across many sectors, including healthcare, maintain and upgrade well-functioning and compliant heating, cooling, ventilation systems, or HVAC, if you like your acronyms, within their building spaces. But for me, compliant is a key word in that statement, and it's one that, when it comes to indoor air quality, has actually held us back in many facilities. Unfortunately, meeting the bare minimum standard has become, in most places, the norm. And in this scenario, everyone loses, especially the people spending time within those buildings and breathing air that really could have been that much better. So the lack of strong regulation in this space is what's given the HVAC industry and the buildings that employ HVAC professionals a little bit too much wiggle room. And as a result, investments in better HVAC design, air purification, as Stéphane touched on, and hygiene practices have been slow, even though we know how crucial these are to the health and well-being of building occupants. That's why in my role within the AIRAH IAQ Special Technical Group, we're focusing on lifting the bar through industry engagement, working with professionals in our area, collaboration with organisations such as Plum and the Safer Air Project and the Burnet Institute. Couple that with development of a new version of the DA26 design application manual for HVAC professionals, giving them a guide in terms of best practices, is where our focus really lies at this point. But obviously in healthcare environments, the urgency around this is far greater than it is in most other settings. And we realise we're dealing with people that are in their most vulnerable states. And on top of that, obviously protecting our frontline workers that are working with and treating these people on a daily basis is something that's really not an option right now. It's absolutely essential that we find a way forward to improve how we operate within these built spaces. I'll touch on probably just a couple of quick technical aspects just before I wrap up. But from a HVAC system standpoint, there are obviously your larger upgrades, your more costly upgrades to have large impacts on buildings, but We also need to be conscious that there are also low-cost quick wins that can be deployed to at least get moving forwards as we work towards what does that nirvana look like in terms of indoor air quality. Starting off, first one is probably a very obvious one, is the filters that are installed within our systems, making sure we have the right efficiency and good quality filters that are replaced on a regular programmed basis based on factors of the building. But it's also important to make sure that those filters are installed properly and they're sealed. Otherwise, we've seen it in many facilities. They have the best filters available, but they're poorly installed and they have gaps and they have leaks, and essentially contaminated air can just bypass them. Ventilation rates is obviously something that's been talked about throughout the whole pandemic. Once we got to the stage of recognizing it's airborne and bringing in more outside air to our facilities. So reviewing ventilation rates, are we bringing in the correct amount of outside air? Helpful for diluting and removing airborne contaminants like viruses and allergens, etc. Routine HVAC maintenance is probably the obvious one, but one that can quite often just be overlooked or not done to a level that's acceptable for driving indoor air quality improvements. So making sure you're holding your HVAC contractors and providers to account, make sure we're doing things correctly. Air purification, I'm sure we'll touch on more as we work through, but that's a relatively low cost option. And during the pandemic, I know we've seen in a lot of GP clinics and allied healthcare settings that portable purifiers were installed and deployed across many locations. Unfortunately today, we'll probably find most of those are either sat in the corner collecting dust and turned off, or running with dirty filters, which in that state, they're probably doing more harm than they are good, as they're sat in the corner giving occupants and visitors to those spaces a false sense of security. There's lots of solutions out there. Our industry is obviously tasked with driving those and getting those out to the customers and facilities to let them know what actions they can take. But yeah, we'll probably get more into it as we work through the discussion further on. But my closing kind of comment would be, if you're considering changes to your systems, HVAC, BMS systems, or implementing IAQ solutions, consult with professionals, speak to others that have rolled out similar initiatives, and learn from what's worked and what hasn't. Thanks, Plum, and I'll pass it back to you.
Brilliant. Thanks, Derek. Some loads of great things to talk about there as well. And I saw someone had commented in the chat about ASHRAE 241, and I think we can definitely get into a discussion around what would it take for an ASHRAE 241 standard for Australia. So perhaps that might be a question we can get to later. Okay, so thank you very much for all your thoughtful remarks. I'm so delighted to have so many of you here, because I think we've covered off all of the areas that we need, all of the experts who need to be in the discussion are in this discussion. So it's time to bring everybody back. Sorry, Derek, you've disappeared, but time to bring everybody, there you are, you're back again. We'll bring everybody back and get ready for our panel discussion. Now, I've been fiddling around with my screens to try and make it easier, and it's made it more difficult. So just bear with me a second and I'll try and fix it. Okay, I have got my questions again. So I thought we might kick off with some, a number of people mentioned around, the patients and the lived experience. And for, I think it was Donna who really, focused on the need to put patients first. For us at Safer Air Project, putting the lived experience of people at the centre of this discussion is the whole reason why we exist. So our first question is going to be to Donna and Glen. You both touched on it briefly, but from a patient's perspective, how has airborne infection risk and indoor air quality, or a lack of attention to it, impacted your own experiences, or those you know of, over the past few years, and how are you navigating that even now in 2025?
I'll go first. Glen, you can jump in after. I think for myself, my whole behaviour has changed. I don't leave the house without a mask. I figure I have enough chronic illnesses myself. I don't need to collect any more. And it's the same for my husband and my son. We mask whenever we leave the house. Queried by many, and now mostly people within our area, you know, dog walking, all the rest of it, there is no queries. It's all quite normal to see us being the lone maskers wherever we may go. I still get challenged in health settings, and I find from a patient perspective, having the confidence to advocate for yourself, and I have been advocating for, you know, well over a decade. I still find it challenging. And I think maybe there's also that, you know, bit of misogyny, whether you're male or female practitioner, but that misogyny that you don't really know what you're talking about. And, you know, I do have a master's in health research. I have been told by a GP that I needed to read less. I did suggest maybe it was time for them to start reading more. But I think if patients, I think there's also that education side of it for patients, because if you don't know, you don't understand the risks that you're putting yourself and others, you know, putting yourself that you can, they're manageable risks. But I know that my behaviour has changed. We definitely don't venture out as much as we used to, and we control as much as we can that in the settings that we might have friends around, or I'm known we're having building contractors, and so I have masks at the door, and they've all been really quite comfortable doing it for me. I just ask nicely and provide masks, so I'm very thankful for that. I'll let Glen jump in.
Yeah, thanks, Donna. Look, I would agree with a lot of what you said there, particularly in relation to how it's changed the way you live in a very large scale way. You know, obviously, in my particular case, I've got a rare thyroid cancer, which I've had for 20 years. I've had heart conditions and heart operations, and a conga line of a range of other health conditions. So the last thing that I want to do is catch infectious diseases that are going to impact me, you know, in a way that will be even more detrimental. I think what people forget in this space is that people who have these conditions, people who are vulnerable, they already bear the brunt of a range of life's challenges, not just in the health space, but just in engaging with the world. And in not having healthcare environments that are safer, particularly in relation to the indoor air quality, you are asking people who are already bearing the brunt of many challenges to bear the risk of this even further. There's a tremendous amount of unfairness and inequity about this. In Australia, we talk about health equity. It's a big talking point in public health and in healthcare. Well, it's just talking. It's not real, particularly when it comes to this issue. So, you know, for me personally, you know, I don't go out as much as I used to if I'm going to be in an environment that might be a closed indoor area. I'll avoid that like the plague, literally. Literally, no pun intended. You know, and so having to think about more things than what I used to, particularly coming from a health background, a public health background, and understanding the risks, that probably does make it worse. Whereas if people are not aware of the risks that they're being exposed to, they may not even understand what is happening in those situations. So it's impactful.
Yeah, absolutely. I couldn't agree more. Being part of a group of people who understand the risks of airborne infections, and seeing people living with cancer who perhaps haven't been given the same information from their clinicians, and we can get into it with Bronwyn. You know, how do we make sure that people living with chronic health conditions actually, you know, it doesn't have to come down to their health literacy, whether or not they are safe in a shared indoor environment and in a healthcare setting. And I just had a quick question for you, Donna, before we moved on. Do you find you get less pushback from the tradies on wearing PPE than you do from healthcare professionals?
Yes. Astoundingly, yes.
Yeah.
And I do preface this and say, you know, we have immune compromise. My son has long COVID. Would you mind? No, not a problem. So it hasn't been a problem. I agree. I have more issues with healthcare professionals. Yeah,
it's definitely something we can work on. Okay, so on to another question about from your perspective, you know, is indoor air quality currently being treated as a priority? I think it might be a slightly loaded question. And are we investing appropriately to make meaningful improvements? And maybe Bronwyn or anybody else you might like to jump in on that. Are we investing enough to make meaningful improvements for patients, or do we need to step up?
Oh, well, look, if everyone's happy that I take that one first, look, I think that we're right at the start of the journey, unfortunately. I mean, I mentioned my background is in tobacco control, and I feel like this transition that we need to go through, which is where Australia is today, and we need to acknowledge we need to get to an indoor air environment in Australia where routinely we can expect that the air we breathe is clean. So between today and that point, I think it's going to take quite a while. But if we think of tobacco control back in the 80s when I grew up, I mean, tobacco control was really in its infancy. And if we look at today, we haven't completely cracked the problem, but we've come a long way. And I think that we need to think of indoor air quality a little bit like that, in that there are many, many things that we can do, and we just need to get started. Some of the easiest things that we can do are to educate people, in particular to educate our healthcare workforce. When I discuss this issue with my colleagues in healthcare, largely they just don't know about it. Mm-hmm. They honestly don't know about it. These are super intelligent people who absolutely want to do the right thing for their patients, but they don't know that air quality is a key fundamental requirement for good health, and that our healthcare settings need to have guaranteed clean air. I mean, just as a consumer myself, when I take my children to the GP, we have an amazing GP, but to be honest, I've taught her an awful lot about air quality, and because I have a great relationship with her, she's taken that on, but she's the only GP in that whole clinic that has an air purifier in her room. She's the only GP that asks her patients to put on masks while they're waiting in the waiting room, and she will mask when she sees us proactively. She's got one on before she sees us. But I think, we know that GP settings are where people go when they're unwell. Mm-hmm. So by default, we know that there are going to be infectious diseases swirling around in the waiting rooms of our GP settings, and we know that that's the case in emergency departments and in other healthcare settings all across Australia. So we need to start taking steps on this journey, and we need to start taking them now. I am very pleased that I've had numerous conversations with our leaders in Canberra who sit across a whole range of portfolios. I think that's one of the other sort of challenges of this issue. We don't just need the Prime Minister and the Health Minister. We need, the Education Minister. We need the Disability Services Minister. We need Science and Technology. We need so many different areas. We need their leaders to sort of buy into this and be aware. But look, we are having fantastic conversations with those leaders. Obviously, I think in the last hour while we've been talking, I think there's news that the election's going to be called tomorrow. So we will, obviously go through that period, and whichever party is in power from May and beyond, we're very keen to work with them to truly invest in this problem, recognise it's an issue, and recognise that there are many practical steps that we can take immediately and in the medium and long term.
Yeah, absolutely. I think there are so many things that we could be doing now. And we were talking to someone, Amy and I were talking to someone really recently, about an indoor air quality action plan. You don't have to, we just have to start somewhere. And that means, for the GP practices that invested in air purifiers a couple of years ago that now have them sitting languishing, turned off. Whenever I walk into my GP, I turn the air purifier on because they have them. And now my GPs just know that I'm the person who turns them on. Wouldn't it be nice if they were turned on before I walked in, or before anybody walked in? And you're exactly right. The very fact that someone is accessing healthcare means that there is an acute vulnerability. But what about when someone is a parent, and that parent is an immunocompromised person or severely immunocompromised person, and that parent is taking their child with the broken wrist to healthcare? So we often access healthcare settings not just as a vulnerable patient, but also as someone, a high risk carer, and we need to recognize that actually people living with chronic health conditions are in every shared space. So I think it's really important. Stéphane and Derek, you are being very patient, so thank you very much. I've got a question coming up for you both. Well, this is really a Stéphane question, but we can cut it two ways. Do we have reliable data to measure how effectively we are protecting both patients and staff? And what gaps do you see in the current approach?
So that's a question for me. It's it's a very, very difficult question because we don't have a standardized approach to healthcare associated infection across Australia in terms of surveillance. So that's something that we know we don't have already. So different states and territories do different things with regard to healthcare associated infection and what is monitored. So first step would be to have a standardized approach across Australia. That would be a good thing to do, and maybe that will come through the establishment of the Centre for Disease Control. But at the moment, we don't really know because from what I understand is infection prevention and control will still be the remit of the Australian Commission for Quality and Safety in Healthcare and not really of the Centre for Disease Control, Australian Centre for Disease Control. So it's a space where we, as a college for infection prevention and control, we're doing a little bit of advocacy. I just want to go back on one of Donna's comment and Bronwyn and Glen also did it, that it is that they find that tradies, especially Donna, are adopting those protective behavior better than healthcare workers. And I think there's still a lot of paternalistic approach in healthcare, and we, as clinicians, we know better than our patient. And I think we need to move on from that and really work collaboratively with the patient and design this infection prevention and control system that work for clinician, but really work for our patient, resident, client, however, what terminology we use, but really design this system together and making sure that we have adherence to the system from the clinician and from the person seeking care. And I think that's something that we have a lot of work to do in terms to have a compassionate approach to infection prevention and control rather than having a punitive approach to it. And that will go a long way in addressing some of these issues. And it's a little bit out of scope from the question you asked me. But,
No, I think it's a great answer. And one of the things, just to go back to, you were talking about the Australian Centres for Disease Control and the more of a community approach. I know that a lot of us on this call, or on the panel, are also parents. This obviously is not just about infection prevention control in healthcare, although that's the subject of today's talk. But we also need to think about infection prevention control in schools and in other public settings, so that we make sure that actually there aren't infections, school-acquired infections, as well as healthcare-acquired infections, but school-acquired infections aren't coming into families and then spreading. So I think the move for infection prevention control to move to the Australian CDC is obviously one that would have quite an impact, because it would take it away from being just about healthcare and make it an all of community thing. So I think I can guarantee the Safer Air Project is very supportive of the ACIPC for that advocacy. I think it's really important. Derek, question for you on technology. you mentioned a bit before about technology. It plays a really increasing, as we know, an increasing role in indoor air quality management. What innovations or approaches do you see as having the greatest potential impact in healthcare settings? Are these technologies being widely adapted? And to kind of merge in a bit of the question to Stéphane, what kind of data do we have on healthcare settings using technology and ventilation rates and things like that? So sorry, that's a big ball of a question bundled up for you. Sorry.
No problem. I'll do my best to try and cover it. I guess it's an interesting question, and I guess just touching on the first part that Stéphane said, it's very difficult to determine just what data is available in that healthcare setting, and not just healthcare, across almost every industry and sector out there. The data that's available in terms of indoor air quality and how buildings are performing is just, it's not there yet. It's still very immature in its stage of development. We have some manufacturers out there that are kind of really leading the field in that area and are driving innovation to have indoor air quality monitoring systems that will integrate with the building's BMS. It can then drive changes through those HVAC systems to deal with real life, live building conditions to adjust outdoor air ventilation rates to improve conditions within a building, to lower or raise humidity, temperature, etc. But the indoor air quality monitoring section for me is probably the most exciting technological advancement right now. There's some really good ones out there in the market, but as with everything, all sensors aren't created equal. So you need to be aware of that, and when you're making investments, make sure you're making investments in the areas that are correct for the facilities you're putting them in. Outside of the sensing technology piece, we've seen Plasma Shield, who are an Australian-based company, really kind of putting out some really great case studies and some science in behind what their product can do in terms of air disinfection within HVAC systems and through new or retrofitted solutions. Like it's really kind of showing some good promise in that area. It's funny, really. When I looked at the first question when you sent it through the other day, Plum, I went into ChatGPT because I see machine learning, AI, all of those things they're here and they're fresh and they're exciting, and there's a lot that can be used in this space. But I asked it a question. I just made a note here. Let me just find what I wrote down. So I went to ChatGPT and asked it, when designing a ventilation system, what would be your main concerns? And straight off the bat, I got a great answer, which was kind of what I expected. And straight number one on the list was air quality. Awesome, great to see it there. Followed by airflow, distribution, and then other factors that go into designing and building ventilation systems. I then asked it, if I asked you this question 10 years ago, what would your answer be? Because a lot of the buildings we're dealing with today are 5, 10, 20 plus years old, and we're having to look at retrofitted solutions into those to improve that. And the answer I got back in ChatGPT's own summation of it was, my 2015 answer would be more traditional, code-driven and efficiency-focused with basic automation. You then fast forward 10 years to today, and the answer for today would be heavy emphasis on IAQ, smart controls, occupant health, and integration with smart buildings. The difference over that 10-year period and how we're looking at it as an industry and what we're doing to drive those changes, we're clearly dealing with a legacy issue of older buildings, and what do we do with those? So the technology piece is going to be really important in how we drive that forward.
Yeah, absolutely. I love that ChatGPT knew the answer. It's fantastic. We should get it to write our infection prevention control procedures for healthcare settings. Okay. I have got a couple of questions before we open it up to some of the audience. And don't forget, if you're in the audience and would like to submit a question, please do put it in there's a Q&A function as well as the chat. So don't forget to submit your questions, please. Starting again with Donna and Glen, obviously as patients and also as the founder of many patient organisations, I'm really interested in what your thoughts are and what patients can do for themselves. I'm very much of the opinion that the burden of responsibility should not fall to patients. But what can patients do in this situation, and what can patient organisations do to better support their high-risk communities so that it doesn't fall on individuals? Donna, you mentioned earlier about advocating. I mean, I'm here. I founded a charity, so I'm pretty okay with advocating. But I find it really difficult when advocating for myself. And I've been at a it's really hard. Advocating for yourself is really difficult. And I was in a clinician appointment this week with a family member, and I just let it slide, and I kept an eye on the air quality. I had a little air quality monitor, and I kept an eye on it. But really, I think we can do better than that, and it shouldn't come down to individuals or parents having to say, have uncomfortable conversations. So what can patient organisations do to help individuals?
I'm always for empowerment of knowledge. So I think giving them the ability to make the risk assessments, where to go, what timings. I make my appointments first thing in the morning.
Yep.
Basically hoping that the air's cleaner then. It hasn't had 45,000 people through already with the dirty air. So I think those easier decisions, but also what for patients, what are their what's their test points? Like some people, like for me, I beginning, and I sometimes still do if it's a really high risk area, take my own little portable air purifier if I know I'm going to be somewhere for a long period of time, because I know that it doesn't do much for that 5 seconds that I'm in a room. So I think, what is their touch points? What are they prepared to do? And I think you can give them the choices that these, it's a P2 mask, it's wearing, it's air quality monitor, it's doing all those little things and taking a little portable air purifier. Are they things for, they may not be for everyone. They might just prefer to not do any of those things and go earlier in the morning. So I think it's just about in giving them a little bit of knowledge to be able to how they can self-manage those situations. I think having conversations with health practitioners might be a little bit too much, but I think advocating as an organisation, having that advocacy and education. So it's not just education of patients, but it's education of practitioners and store owners. And, did you realise that you're providing a air purifier will be a tax deductible, add to your, I did marry an accountant, so that does come through, but, it's just those thinking. Even, I went to my therapist this morning and that was a conversation. She said, what are you doing next? I said this, and you know what? You should tell them they've just renovated their rooms. Why don't they add an air purifier in there? So I just drop little pieces. I don't want to overwhelm. So I just litter little pieces, but I think it is about education and what people's pressure points are.
Yeah. Bronwyn.
Yeah, thanks, Plum. Look, I just wanted to jump in there because I think it is a dreadful situation to think that we should be telling people to go to their health, to seek their healthcare early in the morning, because that's more likely to be safe than later on the day. I know that that's a fact. But just standing back here as someone who's been in the healthcare sector for, I don't know, I started at university in 1993, so whatever that works out to, a very long time, I feel ashamed that we're at this point, because it should not be up to patients to carefully curate their healthcare seeking schedule so that they might possibly not get a disease that can cause them serious harm when they're seeking care for an unrelated problem. I think it's disappointing we're at this point, and I just don't think that obligation should ever be placed on a patient. I think Australia has always had an excellent healthcare system. I've always been just so proud to live in a country that cares so deeply about providing safe and accessible care that's free for everybody. That is not the case in many parts of the world. And I'm fully aware of that. And I've always thought that we're just so unbelievably fortunate to have that here in Australia. I think we've deviated from that in recent years, and we need to come back to the basic principles that we've always held so closely to our way of life in Australia. And we need to acknowledge we can do better. We've lost our way a little bit. We can do better. And we really need to, I think, reset what we're doing in Australia, acknowledge that indoor air quality is a gap, and get going, because there's so many great solutions out there. But I just wanted to say that because I just find it really heartbreaking to hear Donna say that. And I just don't think that is her responsibility or the responsibility of the patients that she represents.
Yeah, absolutely agree. Glen?
Look, Bronwyn and Donna are spot on. Over the, during the pandemic, and as it continues, because it's still continuing, I personally have seen my risks increase, not decrease.
Yeah.
Instead of the opposite. So with all the knowledge, so as knowledge about this has increased, the risks to patients has also increased instead of decreased. There's a serious dissonance there. But to add to some of Donna's comments earlier about what can patient groups do, look, I think there's a lot they can do. It's probably potentially some lack of awareness of what they don't know that they can do. I think it's informing some of these patient groups as well. It's not just informing their members and their constituents, and it's also on the flip side of that. Obviously, if you have a patient group, there's a clinician on the other side of that equation as well. So it's having those patient groups engage in some way with those congruent clinicians. Also having those patient groups engage with the groups of those clinicians. So, if you're, it may be the head and neck surgeons or ENTs or what have you. If you've got for example, I'm on the board of the Australian Society of Head and Neck Cancer. That's primarily clinical based, but there's also a patient group in the same area. So there has to be more collaboration with those professional organisations. And I think a lot of patient groups need to basically get together and in a coalition and advocate for this collectively, because independently it's too big to do on your own. Your project here, the Safer Red Years charity, Donna's Red Cancer Australia, that I'm a patient advocate there for, and on the patient advisory board. Individually, it's too big to move this needle, but together, I think that we can, and it starts becoming more politically and electorally interesting, let's say, when there's a bigger movement for this, especially when you have patients and the clinicians together, that more so. So I think that's an important aspect that needs to be looked at.
Yeah, absolutely. Thanks, Glen. I am acutely aware that we are rapidly running out of time, and although I still have a few questions, we also have some coming from the audience. So I'm going to jump to one. This is really a Derek question, maybe Stéphane, maybe Bronwyn, maybe everybody. Far UVC light seems to have enormous potential to reduce spread of airborne viruses. What obstacles do you think need to be overcome before it can be widely used in healthcare?
Maybe I'll start then, I guess, Plum. Look, I think far UV it's a very young technology. There's a lot of research still going on in that space down to its deployment and efficacy. So I think at this point in time, it's a great solution to look at, and Thrive IAQ and Lydia and the team there are doing some great work looking at all the applications of various technological systems, advancements, and supplementary technologies. So I think to give it kind of the tick of approval to move ahead in healthcare at the minute, it's probably just a little bit too early. And we'll let Lydia and others like Lydia who are doing these research projects dive a little bit deeper into that first.
Bronwyn, did you want to add anything?
Yeah, I mean,
about the Elucidar?
Sure. Look, the Victorian government is supporting a study that is being run by Burnet Institute, and that study is looking at the impact of UV light treatment, which at a very high level, it's a very special kind of light that is passed across the top segment of a room, and it completely sterilises the air in that space. So it kills viruses, kills bacteria, all the nasties in the air just get wiped out. And Derek, you'll have to correct me if I'm wrong. I thought UV light had been around for a long time because it was back in the days of, the early days of TV, it was invented. But you're right in that it hasn't been widely adopted. I do think it's important to know, though, that the solutions are there. We don't need to sort of get bogged down, I think, into sort of the fine detail, because we're actually right at the start when it comes to, deploying just simple things that work. So ventilation that works, air purifiers that work. Interestingly, there is very good evidence from a nice study done in the UK a couple of years ago looking at air purifiers that had UV light integrated into them. They were deployed in 2 wards in a hospital in the UK while COVID was rampant, and they eliminated COVID virus particles from the air. They were brilliant. So these 2 air purifiers with integrated UV technology. But look, my point is the technologies that we do need are already there. We're studying it now in Victoria with this great study in aged care settings, looking at whether the technology works and the impact that it has in aged care. But I think we shouldn't forget that technology that we need, we already have. That shouldn't stop us. And yes, there'll be refinements and advances further on in the future, but there's absolutely nothing stopping us from getting going today.
Derek, did you want to follow up?
Yeah, Bronwyn's absolutely correct. UV has been around for a long time in a different application than what's being used in terms of far UV. So it's a two similar systems with very different applications. The far UV being the new high level sort of roof type level occupied space deployment of UV, whereas your traditional germicidal irradiation UV that's installed in HVAC systems, that's more down the ductwork in the air handling unit, treating the air as it comes through the system rather than in the occupied space. But yeah, it's been one of the most effective systems put in place to date, and it's I guess UV has a lot of applications, and it's just being aware of the application that you are purchasing is the right one for your building. That's where you need to make sure that you're buying into the correct solution.
Great, thank you. I've got a question. There's one from the audience, and it's similar to one that I had, so I'm going to merge them together, which is really around regulatory standards. Do existing standards effectively mitigate the risk? Do they need to be strengthened? And I guess this is both an indoor air quality standards question and an infection prevention control standards perspective. The question that came from the audience, which I will merge it with, almost exactly a year ago today, there was a paper published in Science by distinguished Professor Lydia Morawska, which was a blueprint for indoor air quality standards, and it effectively set 4 parameters. The 3 that are really of interest from a healthcare setting perspective are CO2, PM2.5, and ventilation rates. How well do you think well, obviously, the question around existing standards, we obviously don't yet have a mandated indoor air quality standard. How well do you think current buildings would perform against the standards that were proposed? And also our infection prevention control standards. So sorry, that's a bit of a mix of 2 questions. So Derek or Stéphane, if you'd like to take it on from either angle.
I can just add a little to that because I don't have a lot in terms of, I mean, it as except for a specialized area like a preventive theatre, there's no really, and in isolation, we don't have the standards that are described in earlier Professor Morawska's paper. So there should be, I mean, it need a lot of push to implement that. But at the moment, it's not really something that is implemented, especially CO2 monitoring and all this. We have mandated air exchange and all that in specialised area. But about it, I don't know,
Yeah.
Derek.
Yeah, so we need to move out of the specialised areas. You know, with the points earlier around, you know, we have vulnerable people in all settings in healthcare. You know, saying specialised areas of the hospital need more protection than others, slightly sort of neglects to acknowledge that you can have very high risk patients in any area, including the reception or the cafeteria.
I think, yes, and I think it goes back to what Bronwyn was saying and Donna about putting the responsibility on the person seeking care. And I think it's moving on from that, and adopting the standards is moving on from putting the responsibility on the people seeking care. And empowering is extremely difficult. You know, I was cannulated not long ago without somebody wearing gloves or putting any antiseptic on my hand. And as an infection prevention and control person, I couldn't bring it up. I couldn't say anything. So when you ask somebody to stop a procedure because they're not wearing gloves or wearing masks, it's extremely difficult. It put the person seeking care in a very vulnerable position. So it needs to come from us. And I know, I mean, as a clinician, I know there's people talking about, you know, the fatigue, about wearing masks and all this, but if we were in a different type of epidemic, if we were in an Ebola zone, we would be doing things differently. I'm not likening COVID with Ebola, but, you know, we have ways of enforcing mask wearing. We have ways of factoring, you know, behavior changes, factoring breaks and all this, but it's not easy. And I think that's what's happening. It's in a too hard basket because we don't see the effect straight away. If somebody was bleeding profusely, we probably would do things a little bit differently. Yeah, and I know I'm being a little bit inflammatory, but
no, I think you're absolutely right, and I always like to think about it isn't just the acute action of breathing now in a shared space. It's the fact that in a day's time, I could have picked something up and be infectious, and I'm now infecting the people that I'm sharing space with tomorrow, and in 3 days' time, and in a week's, you know, the consequences aren't just an immediate here and now. There are flow-on consequences from the air that we share at any given point. Donna.
I think, you know, the fatigue side of things about COVID, I think there's a lot of PTSD around lockdowns, not necessarily COVID, but the lockdowns. And I think there needs to differentiate between the two. But the fatigue for a healthcare worker to not use appropriate PPE or have clean air, would you expect a firefighter not to, you know, put it into a different industry? Would you give them a leave pass because they're traumatized because of bushfires? You know, like, we don't do that. So why are we, you know, why is it acceptable, or even, you know, this mental state that we have let fester, I suppose, this thought process. Other occupations have requirements, you know, pilots, you know, everyone has their own requirements of OH&S. So why is it not the same thing for healthcare? And putting on a floppy blue mask after the air's already dirty, when you asking me to walk in and go, can I put on a mask? Would you like me to put on a mask? I'm at the point of going, why bother? You're already dirty. Don't worry about it. So I just don't know why there is a different mindset for different occupations.
Yeah, absolutely. Bronwyn?
Yeah, look, Donna, you've made some really good points there, and maybe just to add a few others, because I think about this all the time. Why are we so comfortable with ignoring this problem? You know, the science is clear. Why are we not doing more? And so just to offer some insights or some thoughts there, I think one thing is that air is not clean. When air is not clean, you can't see it. It's invisible. So there can be a whole stack of bugs in the air, but we don't know, and we just consume that air. Whereas if I gave you a glass of water that was a bit grey and brown, you would have this very obvious marker that it's unclean and unsafe, and you wouldn't have it. So the invisibility of air is a problem. The fact that air that has bugs in it, viruses or bacteria, it doesn't cause immediate health impacts. You don't get sick that minute, that hour. You don't even get sick that day sometimes. You get sick a few days later. And that's just the acute illness. We know that if you look at COVID, about 3% of people have long-term problems from that, and they don't manifest maybe for 3 months or 4 months. So that delay of the impact of dirty, unclean air is a problem and allows us to sort of ignore it maybe. And I also wanted to mention that there are not that many advocates out there on the issue of clean air because it is relatively new. I know there's been experts calling on the world to really act on this for years and years, but there is a renewed interest in this, but there still are not many advocates out there. In particular, there are not many people out there who are directly suffering. And again, if you think of COVID, that's because the people who have suffered the most are really sick. People who've got long-term impacts of COVID, they have no energy to do anything, let alone get out there and start organisations. I know that there's a few people on this call who are rather remarkable, but when we're thinking of the broader community, there are not that many advocates out there, and they've sort of exited or restricted their lives so much that they're also not very visible. They're not seen so much, whereas, you know, they are there, they're just behind the scenes and they're unwell. And this really does remind me a lot of lung cancer and tobacco, because lung cancer patients are not out there advocating because they're so sick. So many of them don't survive their diseases. The ones who do are in bad shape. So it's quite, you know, similar in that way. And I just wanted to make one final comment, which is that, Plum, you asked, do we have standards? Where are we with indoor air quality? When we went to meet the Prime Minister, we explicitly asked him to set up a task force of experts, and this would be a government-anointed task force, and the first job would be to set indoor air quality standards so that those who are acting have clear guidance as to what they need to aim for. Those who are thinking about it can start working towards it, and it just provides a clear framework for everybody in every sector to get going. But of course, the healthcare sector is the priority sector to move on this issue.
Yeah, absolutely. And I mentioned at the very beginning that we released a report in November 2024. In that report, we similarly called for indoor air quality performance standards, but perhaps rather uniquely, we called for them as an accessibility issue. So a safe indoor air quality performance standard that effectively reduces the risk to the lowest practicable level of infection with airborne pathogens or exposure to airborne pollutants, because of course it isn't just viruses that can make us sick. It's, you know, PM 2.5, and you know, think about, you know, people living with asthma and stuff. So having these standards, I think, is such an important step forward. Glen, I can see you've got your hand up. Oh, you're on mute, Glen. Almost made it to the end.
Almost. Not directly at the question you just asked a moment ago, but sort of tying a couple of these together. You know, why is there inaction, political inaction? Let's say, because obviously we are acting here. Why is there a perception, or to a certain extent reality, of some inaction on this issue? Well, there's a multitude of reasons why. But, you know, as Stéphane said, if this was Ebola-like and people were walking around bleeding from the eyeballs, there would literally be action immediately. It's the fact that it is hidden, like a lot of chronic illnesses and a whole range of things, where the immediate effects are not felt, that is part of it. But for those of us who are old enough to remember, in the mid-90s, there was this is probably relevant here for this particular topic. There was a study called the Quality in Australian Healthcare Study, which looked at medical errors, alleged medical errors in hospital and healthcare settings in Australia. There was a big hoo-ha made about this at the time. It was enormous, and it actually led to a lot of action. So we went from a case where there was a status quo where apparently nothing was happening. Someone did a study, found a whole bunch of stuff which was there anyway, not there. And then from that actually came a whole bunch of investment, which I believe led to the formation of the Australian Council on Safety and Healthcare at the time in the late 1990s and 2000. That took something like 5, 6, 7 years for that process to happen. We're sort of on that timeline now, but I don't believe that this particular issue has had enough political impact as that one did at that time. So I think there has to be a process whereby this becomes more politically salient for policymakers to engage with. We have to take it from where it is hidden and actually make it more exposed. You know, if we took a whole bunch of people who are in policy making positions and shoved them into a room with some COVID patients and sit there breathing air, you know what? We'll have a conference on this and see how important indoor air quality becomes. You see some immediate change.
Yeah, I like you.
And that's a radical perspective, but it's the reality of it. All of a sudden, oh, you know what? Maybe a mask is important. Oh, air purifier might be important. UV is important. You know,
I like the thoughts around making the invisible visible, and I think that's what we really need to do. We need to sort of shift not just the air being invisible, but also people living with chronic health conditions as being invisible. We're getting very close to time, so I want to just give everybody else just a chance to say a sentence or two as a final thought. I'll go round from the top. Derek.
Yeah, look, I think at this point in time, there's a lot happening in the background that's probably not obvious to everyone. From an AIRAH perspective, we're working with people who are involved in the ASHRAE 241. We're working with yourself, Plum and Bronwyn as well, with some of the conferences and things that we're doing, raising that awareness and trying to get more people engaged and involved from an industry perspective. But overall, from a building owner, occupier perspective, is take that first step.
Yeah. Fantastic.
We can hold on and wait for perfection, but it's never going to come. The important thing is to take that first step now to move towards what better looks like.
Yeah, thank you.
I think to go with that again, it's again working with you and other organization and really bringing the infection prevention and control profession into the journey and acknowledging, you know, what we haven't done, but now going to really championing that good indoor air quality makes sense and for everyone.
Thank you. Bronwyn?
I think it's just important to remember that there's this huge opportunity that awaits us now to really return Australia to having a reliably safe and accessible healthcare setting and network, which is certainly something that we don't have right now. And it won't just be good for some isolated groups in the community. Everybody wins when it comes to better indoor air quality. It's rare, I think, if there's, government, when we're advocating to different ministers, it's rare for policies to impact everyone in a good way. But indoor air quality is one of those, and it will also really build resilience within the healthcare setting for the future, because it doesn't matter what the name of the bug is, indoor air quality will ensure that the air is clean and safe, and we're always going to need that today and in the future.
Absolutely. I did have a question that we haven't got to, which was about being pandemic proof for the next pandemic, and absolutely, acting now means that, when H5N1 does finally take off, we're already ready for it. Donna, you just some final thoughts.
I just keep nodding because I'm like, yeah. I think as we talked about, a collective voice, having everyone advocate together for change, and in my experience, having a dollar value attached to the cost to the economy for not having clean air, and I don't know how that's quantified and who may be leading that research already, but having that will help change what is the cost to the economy, what is the cost to society for not doing it, will help shift the dial. It's what sort of helped us with endometriosis, and hopefully we're able to do that for other states and come together. And as you said, there's not many places that can say it's going to help everyone. This policy will help everyone.
Yes, absolutely. I think the cost of inaction is a really good way of looking at it. What is the cost of healthcare acquired infections? What is the cost to our workforce? What are the costs of preventable infections? We already have data that shows that there is a return on investment, and we will have to get into it in another webinar. But the return on investment from improving indoor air quality is also there. It is an opportunity for us to grasp. We just have to make the steps to do so. We're going to wrap it up there. Unfortunately, not unfortunately, we've gone slightly over. It's been a fabulous discussion. Thank you so much to all of you for joining us. To our outstanding speakers, thank you for bringing such brilliant insights and perspectives, and for having such a fantastic discussion today. I think for me, the really key takeaway is that patients shouldn't have to be self-advocating for themselves. If even the president of the Australian College of Infection Prevention Control finds it difficult in a personal setting to advocate for a healthcare worker to use the best infection prevention control procedures, then what hope do the rest of us have? It shouldn't be up to us as patients to have to advocate for safe healthcare. Everybody should be safe. That's the whole purpose of healthcare. So yeah, thank you everybody. Thank you very much to our audience for taking the time to join us today. There are many ways that you can get involved. I'm going to rush through them very quickly. Please visit our website, sign up to our newsletter, follow us on LinkedIn, Facebook, Blue Sky, all of these areas, and sort of help us become champions for change in this area. Our vision is to create a world where everyone can breathe safely indoors, and that's something that we can only really do when we all work together. A final thanks to our sponsors, particularly our major sponsor Camphil, and our supporting sponsors ERLAB USA and Sealy International. And if your organisation, if you're joining us, would like to get involved, please do get in touch. And that's it. Thank you very much. Thank you to everybody for being part of our community, and we look forward to welcoming you at our upcoming events. So thank you very much. I really appreciate you being here today.